Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. You hear a consultant dermatologist talking to a patient called Jake Ventor. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Jake Ventor? Please come in and take a seat.
Thanks.
Okay, now I understand from your GP that you've got a problem with your hand?
Yes, I went to see a couple of weeks ago because of a sore on my left hand. I've had it for years, but not all the while. You know, it appears, then it gets better, then it comes back. It's here on the palm. It's almost gone now. But she wasn't sure what it was, so she said I'd better see a dermatologist. She took a photo. Did you get that?
I did, yes. So tell me about the condition, how it feels and...
Well, I always know when I'm going to get it because I have this itching beforehand.
Right.
I wake up at night wanting to scratch the area, though I try to stop myself.
Good.
Then a few hours later, I get 1 or 2 little blisters, and they gradually get bigger and join up into one big one. It all feels a bit hot, and the skin around it goes red. When I showed this to the doctor, she used the word chaotic to describe it. Anyway, it gradually dries up, and I get a scab. Then after about 2 weeks, that falls off, and there's just a little red patch, like you can see now.
Okay.
I've been getting it for years. I actually got it the first time when I was in China in the 1990s. I had a job there for a couple of years before I came back here. That first time, I also had a similar sore on my chest, but that's never come back. But the one on my hand, that comes back every year or so, but never in exactly the same place. I thought it had sorted itself out because I didn't get it for a couple of years, but then it came back.
Right.
So there's no pattern. It's not getting more frequent or anything, and it doesn't seem linked to anything in my daily life. Like it doesn't seem to happen when I'm run down, for example, or because of anything in my diet, or if I'm under a lot of pressure at work, that kind of thing.
Okay.
So the doctor thought you needed to have a look. Also because I had a malignant melanoma on my back that was removed in 2006.
Right.
It was at quite an early stage and it hadn't got too deep.
Okay, well, that's good. Still, I'll just have a look at your back.
Mm-hmm.
Was it down here?
Yeah, that's right.
Okay. Well, yeah, that all looks absolutely fine. Well, I don't think you need to worry about anything sinister here. By the way, have you ever had cold sores?
No, never. But I did wonder if this thing on my hand was something like that. In fact, I wanted to ask you about that. There's an antiviral cream you can use, isn't there, to stop them developing? I wondered if you could prescribe me something like that.
Look, the trouble is these work well on the mouth because the skin's very thin there, but I'm afraid they won't have any effect in your case because the skin on your hand's so much thicker.
Oh, I see. Well, something else that worries me is whether there's a chance of infection. Should I be covering the place up?
No, you don't need to unless there's broken skin.
Right, good.
It's fine.
And it's not actually having an impact on my quality of life or anything like that. It's something I can live with. I mean, I have done for all these years.
Okay, so really, the reason you went to the doctor after all these years was just to see if there was any way we could prevent this happening?
Yeah.
Okay, well, at this stage, the best thing to do is organise a biopsy. It might be a bit uncomfortable, but it means we can rule certain things out.
Okay.
Extract 2, questions 13 to 24. Complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mr. Bloomfield. My name's Dr. Dixon. I'm a locum GP standing in for Dr. Wright. What can we do for you?
I've been having some problems with my breathing.
Can you tell me a little bit more about this?
Well, I keep getting breathlessness and wheezing in my chest. It all started about 3 weeks ago, and I've been coughing a lot with it. Some white phlegm. I thought it might be a cold coming on, but then after about another week, I started finding it more and more difficult to catch my breath.
Right. So you've had the wheezing and the breathlessness for roughly 3 weeks?
Yes, give or take a day.
And do you get these bouts of wheezing and shortness of breath every day?
No, they come and go.
How frequently do you get them?
The first week there was only one, I think, and then they started getting worse, 3-4 times a week. It's not being able to get my breath that's really worrying.
And so the attacks, have they increased in the past 2 weeks?
Yes, they're much more frequent.
Okay. When do the attacks come on?
At any time, but they seem to be worse at night and in the morning.
Have you noticed any change in the severity of the attacks, especially in the morning?
Yeah,
Do they wake you up at night?
about 3 times a week.
I see. You been off work at all?
No, but I nearly didn't go in yesterday.
Was that the worst so far?
Yeah.
And have you had anything else with it?
I've felt a bit tight across the chest.
Any pain with it?
No, just tightness.
Are you aware of anything that triggers the attacks?
Like what?
Dust, feathers, new carpets?
No, I can't really say I am.
Okay. Have you had any infections recently, like flu or sore throat or chest infection?
No, not for a long time, except this.
And what about medications? Are you taking anything?
No,
No aspirin?
no,
Are you doing any exercise? Jogging, for instance?
no.
What about pets? Do you have pets at home?
No, but my neighbours have a cat, but I don't see it that much.
Everything okay at home?
Yeah, things are fine.
And what about work? I see you're a civil servant. Any stress or problems at work or anything like that?
Work's been getting me down recently.
In what way?
Well, there's been a lot of changes going on recently, and I suppose I'm a bit anxious, what with the mortgage and that.
And this has been getting to you?
Yes, more and more.
I see. And does the wheezing, etc., continue over the weekends?
No. When I come to think about it, it doesn't.
Okay. Some general questions. Have you ever had anything like this before?
No, never.
Do you have other illnesses? High blood pressure, diabetes, or heart problems?
No, nothing like that. This is the first time I've been ill in my life.
Has anyone in your family had anything similar?
No, not as far as I know.
What about eczema? Anyone in your family with that?
Both my sister and my mother have it.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a doctor talking to a teenage boy who has a painful wrist. Now read the question.
Now then, I understand you fell off your skateboard some days ago and injured your wrist. Is that right?
Yes, I slipped and put my hand out to save myself. My mum says I've sprained it.
You certainly got some swelling and bruising there. But I don't think your mum's right in this case. Does your wrist hurt?
It aches, but the pain's worse when I try to grip something.
Right, well, I suspect you've broken what's called your scaphoid bone. It's a classic injury resulting from what you describe. I can't feel any other fractures. But you'll need an X-ray to see where the 2 ends of the bone are. If they're not meeting up properly, you'll need an operation to sort that out. But let's see the results first.
OK.
Question 26. You hear a trainee doctor telling his supervisor about a problem he had carrying out a procedure. Now read the question.
So how's today gone, Harry?
Well, I'm afraid I had a problem taking blood from Mrs. Harris. I've done that procedure numerous times now, so I wasn't particularly worried. What I hadn't anticipated was the difficulty finding a vein. I suspect her illness means she'll have had a number of cannulas inserted over the weeks she's been here, and that's led to collapsed veins.
Well, that can happen with long-term elderly patients, and it's distressing for them if the procedure isn't done quickly.
Oh, she endured it without a murmur. I'm sure I would have made a fuss in similar circumstances.
Well, I'll supervise you the next time you do it.
Question 27. You hear part of an antenatal consultation at a GP practice. Now read the question.
Mrs. Summer, how can I help today?
Well, I just wanted to check something.
Okay. So you're having a home birth?
Yeah, though everyone's on at me about going into hospital. I had my last child there, but I'm determined to be at home this time, to feel more relaxed as well as safe. But I wondered about an at-home epidural if I wanted it. Going without wouldn't put me off, though.
An epidural's out, I'm afraid, because we can't do it without an anaesthetist. Just pethidine or gas and air. But they're very effective painkillers.
Yeah, pethadine's good.
And you had a bad patch after giving birth last time.
Yeah, I got really depressed. I couldn't understand it. It was short-lived, though, and I'm better prepared now. It can't be prevented, but I have read up about coping strategies.
Question 28. You hear a nurse briefing her colleague about a patient. Now read the question.
Mrs. Green was admitted last night for pneumonia. She came in yesterday with a cough, fever, dizziness and chest discomfort. She's a healthy 60-year-old with a history of right knee replacement 5 years ago. She's on a regular diet and has no allergies. She's at high risk for falls due to her dizziness. We changed her IV antibiotics to oral, which she's tolerating well. Her assessment is within normal limits, except for some mild shortness of breath and wheezing. Her vital signs are stable, oxygen saturation is 98% on 1 litre, and she's been comfortable during my shift. Around 5:30, I gave her 2 paracetamol for minor pain, with good results. She has an 18 gauge in her left arm. She's got normal saline at 15 mils per hour.
Okay.
Question 29. You hear the manager of a care home for the elderly talking to the nursing staff. Now read the question.
Now, a quick word about the administration of medication. It's great to see how carefully you're all following the new guidelines, and thanks to this, error rates, which were always below average anyhow here, have dropped by 40%. The surveys we've done also throw up some interesting findings, like mistakes being more common in the morning than afternoons or evenings. We're not sure why, but there's a clear pattern. Also, we know that being disturbed for any reason while working out and preparing doses is a common reason for mistakes. So please, try and avoid distracting your colleagues while they're doing this. Finally, we must be on the lookout for drug interactions, side effects, and patient sensitivities. Fortunately, we haven't had too many problems of this nature, but the care needs of the vast majority of our residents are often quite complex.
Question 30. You hear part of a morning briefing on a hospital ward. Now read the question.
Right, so overnight admissions to the ward. Greg, could you start us off?
Sure. We have Sue Deans in bed 5. She's a 54-year-old female who was brought into the emergency department by police overnight. She has a history of poorly controlled paranoid schizophrenia. She presents with chronic persecutory and paranoid delusions and also significant thought disorder. She's to remain in high dependency unit care until the stabilisation of her symptoms. We'll be observing her every 15 minutes and monitoring the level of her distress, psychosis, and any response to interventions offered.
OK. I'll review the clinical and detention status this afternoon. Now, what's the plan for discharge?
Social work interventions required for placement and community support options, and that's been booked for tomorrow. Also, an application for the appointment of legal guardian may be required.
Right. We'll consider that at tomorrow's ward round.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an occupational therapist called Anna Matthews giving a presentation to a group of trainee doctors. You now have 90 seconds to read questions 37 to 42.
Hi, my name's Anna Matthews. I'm an occupational therapist working here in the hospital. In a moment, I'm going to present a case study to you to show you the type of work I do. But first, let's think about what we understand by occupational therapy and the part it plays in patients' recovery. In simple terms, therapists like me help patients of all ages to participate in the things they want or need to do through the therapeutic use of a range of recognised activities. For example, this could be helping patients who are recovering from illness or injury to regain skills and get back to work. Or it could be supporting older adults who are going through physical and cognitive changes. What I always have to keep in mind, however, is what the individual wants to achieve. I always say that a doctor's first question is, what's the matter with you? Whereas my first question is, what matters to you? Now, onto my case study. It involves a patient called Ted, a 60-year-old man whose motorbike was in collision with a car. Luckily, the accident happened at moderate speed, but he still suffered compound fractures in both legs, in one arm, and several broken ribs. When I first met him, after 2 weeks in hospital, he was physically and emotionally broken. After all, not only was his mobility in question, but much more importantly, so was his style. Doctors had told him that he might never be able to squeeze into his motorbike leathers again. So he'd given up. Imagine how he must have felt. One day, totally independent, and the next, suddenly unable to do things anymore. Ted showed little interest in receiving treatment. Some colleagues at the hospital took the view that if he stubbornly refused to help himself, there was little they could do. It was his right, they said. But I didn't agree. Since Ted couldn't use his legs or right arm, I made sure we concentrated on what he could do with his left hand. For example, I worked on strategies to help him dress himself and things like that. We even worked on fine motor skills, like writing with his left hand. I wanted to make sure that even if he didn't ever regain use of his right arm, I could at least get him to function by whatever other means were open to him. So, how did my therapy help? Well, I worked with Ted on his hands, putting playing cards on a table and getting him to pick one up, which he couldn't do. But he then resorted to sliding the cards off the table and picking them up that way, finding a way of compensating for what he couldn't do. He'd become upset about what he felt was his lack of progress. Relearning to do things you used to do with ease can be frustrating. But in time, I got him to see that if he didn't work with me, then he'd stay as he was for the rest of his life. That was a big motivating factor. Ted had therapy for 8 months, and he had his ups and downs. For example, the day when he finally had the plaster casts removed from his legs. He built it up in his mind into a great step towards independence. In reality, of course, it wasn't. He was still unable to stand because he'd lost a lot of strength, and the doctors were still predicting he'd remain in a wheelchair. Although I'd warned him about all this, that moment still came as a big disappointment. But strangely, when something like that happens, it can be a turning point. Like many patients, Ted became even more determined to regain mobility after that. Anyway, you'll be delighted to know that Ted's story had a happy ending. He's now back at home and back at work too. Learning to walk again took every ounce of energy he had. But patients like Ted, with that fighting spirit, go from strength to strength after discharge. That's where the support of family can be invaluable. As long as they don't inhibit the patient by warning them of potential dangers at every turn. But patients like Ted tend to take charge of their own ongoing recovery, gym membership, therapy regime, that kind of thing. Seeing that gives me a real sense of pride in the work I do and the difference it can make to people.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
New research from the Perkins Institute at the University of Sydney claims to have found the diet that boosts FGF21 levels. One of the lead scientists on the study was Samantha Solon-Beat of the Perkins. Welcome to the Health Report.
Thank you for having me.
So what is this stuff, FGF21? I mean, it's almost eye-crossingly complicated from the look of it.
Yeah, it seems complicated, but it's actually not. And recently, there's actually been an immense amount of interest in fibroblast growth factor 21, or FGF21. And this hormone has actually recently been called this fountain of youth hormone, which we know can be influenced by diet. And the reason why FGF21 is so interesting is because high levels of this miracle hormone, as it's called, has actually been shown to play a huge role in influencing appetite, improving metabolic health and immunity, and even extending lifespan in mice.
Now, something that sounds so good to be true is usually too good to be true.
At this point, there are no adverse effects shown with increased levels of FGF21. In fact, a lot of studies are now being done to investigate FGF21 as a therapeutic target for the treatment of diabetes and cardiovascular disease.
Let's just double back, Sam. A year or so ago, we had Steve Simpson, who's the director of the Perkins Institute, talking about this 25 diet study where they studied 25 diets in mice to see if you could replicate the life-prolonging effects of a low-calorie diet, where extremely low-calorie diets in some animal species, in fact all animal species, it seems, apart from humans because it's not been proven yet, increases life expectancy or lifespan. Is the FGF21 really the heart of this matter?
We think it actually could be. Certainly in this study, we've shown that a diet low in protein and high in carbohydrate is the most effective way to increase levels of this miracle hormone. And that this diet was also associated with several markers of improved metabolic health in mice.
So tell us a little bit about this study.
Well, what we actually did was performed a really large mouse study, as you said, where we took 858 mice and offered them a range of different diets to see how macronutrients, such as proteins, carbohydrates, and fats, as well as total energy, could interact and influence levels of FGF21.
And you found?
And we found exactly that we could use diet to increase the levels of this FGF21 hormone, and that a low-protein, high-carbohydrate diet was the most effective way for increasing this miracle hormone.
And what effect did that miracle hormone, I hate using that word, that phrase, but what effect then did the hormone have on these mice, or were you able to separate the two?
We were actually able to show that the exact diet that increased FGF21 also improved things like insulin sensitivity, glucose tolerance, blood pressure, and blood lipids, even though the animals were a little bit fatter.
And how do you know that was anything whatsoever to do with the FGF21, your so-called miracle hormone, and rather than it just being an accident that it was raised to?
What we did was plotted FGF21 using the geometric framework, which is a nutritional modeling platform that helps us tease apart the role of nutrients and calories. And if you line up all the surfaces, the response surfaces in this framework with FGF21 and all the metabolic outcomes, you can clearly see that there's a specific area in the nutrient space that coincides with increased levels of FGF21 and several metabolic benefits.
And what kind of carbohydrate, and what happened with fats?
In this study, fat did not appear to have an effect on FGF21 levels. It seemed to be low protein was the primary driver, and that the highest combination was with a low protein, high carbohydrate diet.
So what does FGF21 do to the body?
And that's a really good question. And that's really the next step of our study. We want to understand how FGF21 signaling works in response to diet to mediate all these beneficial outcomes.
Do we know that were there any medications affected?
At this point, no.
It seems that it goes up with starvation, it goes up with overfeeding. There's lots of things that influence it. Did the appetite of these mice change? Do they eat more or less when the FGF21 goes up?
Oh, that's a really good question. See, this is one of the things that we were able to reconcile in our studies. As you mentioned, a whole range of literature in previous studies have shown that FGF21 is elevated in many paradoxical conditions such as starvation and obesity, high intake of food and low intake of food, as well as in insulin resistance and in insulin sensitivity. So what is going on here? Using the geometric framework, we were actually able to tease apart these findings, showing that reduced protein intake is the primary driver of FGF21.
Okay, so what happens in mice does not necessarily happen in humans. How do you know it makes any difference at all in humans?
Oh, I'm glad you said that. We've actually published work just this year showing that FGF21 levels in humans is also increased by a low-protein, high-carbohydrate diet. And of course, this is really exciting because it tells us that the work that we do in mice can be directly translatable to humans.
So is there any evidence at all that FGF21 has the same beneficial metabolic effects in humans as it has in mice?
Yes, there is definitely evidence to suggest that high FGF21 levels is directly related and associated with several benefits of metabolic health in humans as well.
So we should put it in the drinking water then, do we?
Yeah, probably. That seems to be the case, yes.
How would it work? I mean, obviously, a hormone like this is probably destroyed in the stomach. This is not something that you would give directly to people, I assume, in the therapeutic context?
At the moment, it's difficult to do chronic administration to humans. So what's happening in terms of drug development is trying to develop mimetics of FGF21 and analogs. So not exactly administering this hormone per se, because it would require chronic injections or chronic administration.
So almost nothing that's touted as a breakthrough or a miracle by scientists turns out to be so. What are your modest expectations of FGF21 in humans?
Well, in humans, we actually think that FGF21 is extremely promising. We think that, at least in humans, we've shown that FGF21...
So a treatment for type 2 diabetes?
Absolutely.
That sort of thing?
Yes. We've shown that humans seem to respond in the same way as mice. So this could mean that we could tailor our diets and our nutritional guidelines to generate a range of benefits from FGF21.
Is it too blunderbuss? You're describing something that sounds blunderbuss rather than targeted. You're just spraying an effect rather than targeting an effect. If you can do anything with it, it's going to be a very wide set of actions which you're going to find hard to control, isn't it?
At the moment, everyone is very interested at FGF21, but no one really knows its mechanism of action. And it seems to be a race at the moment. How does it work? What turns it on? What switches it off? And what can we do to find out more about it? So at this point, I think it's a really hot topic and everyone's racing to find out the answer.
And you hope you'll be first.
Hopefully.
Sam, thanks for joining us on the Health Report.
Thank you so much.
Samantha Solon-Beat is a researcher at the Perkins Institute at the University of Sydney, and on our website we'll have a link to our previous interview on the diet and longevity study.
That is the end of Part C. You now have 2 minutes to check your answers.